Thank you, everybody. We're very pleased to say that we have a guest speaker here today, come down from Edinburgh Napier University. So I'd like to introduce Professor Lis Neubeck. We're going to hear about recovery from SCAD.
So many thanks for the invitation. It's really a pleasure to be here. And I'm a relative newcomer to SCAD research. So my background is as a cardiac rehab nurse who did a PhD looking at why people don't access cardiac rehab and trying to find ways to engage people who don't go into cardiac rehab to take part in it. And while we were doing that work, it became very apparent, and the UK data supports this, that women are distinctly disadvantaged in cardiac rehab, regardless of their condition. So when we look at the data for people who go to cardiac rehab, it's around about 50% of all heart attack survivors who go to cardiac rehab. But when you split it by gender, 30% are women and 70% are men. So what are we doing that's wrong? And so my interest was, why are we providing cardiac rehab in the same way that we have provided it for 50 years? And we looked at some leisure centre data that Coral, who's over here, had access to, and we looked at what women chose to do. And surprise, surprise, it's not going to the gym and it's not doing circuits. So we know that cardiac rehab is not really what, in its current form, what women want. So I got asked to talk about this at the British Heart Foundation's Bias and Biology group. And I am going to name some important people because these are Mary Galbraith, who many of you I'm sure know, and Margaret Davis. And these two women were involved in that initial campaign. And this is where the power of patients is really important. Because I hadn't met Mary and Margaret, I probably wouldn't have embarked on this SCAD journey. But I spoke to Mary and Margaret after that Bias and Biology meeting, and they told us of their experiences in cardiac rehab in SCAD. And we're kind of appalled at the way cardiac rehab was set up around SCAD, or rather not set up. So we decided to do a systematic review looking at this. Now, we've already heard how much we think SCAD is causing problems in ACS cases, but it's really an important cause of ACS, or acute coronary syndrome, in women under the age of 50. So our systematic review, we first of all set out to find out about physical activity and psychosocial recovery. We'd already looked in the literature, and only 2 programs in the entire world had ever developed or tested a program for cardiac rehab. So the literature is relatively small. So we expanded it out to say we'd look at physical activity and psychosocial recovery. We had no intention of looking at risk factors in SCAD because all the literature suggested to us that actually risk factors weren't a big problem. But as we were doing our review, we discovered that maybe they are, and maybe this is something we should be thinking about. So this systematic review was done in partnership with Mary. Mary kept sending me papers, so I really felt like I had to take notice of the information she was sending us, but also she was an important critic of what we were finding and saying, have you not noticed this? Have you not noticed this? So it's been a wonderful journey for me working with her. So we looked at over 1,000 papers, and we got down to 28 studies that had been conducted all over the world looking at what happens to people after they've had a SCAD. And this is what we found. So in terms of physical activity, there's really limited evidence. And I'm delighted to say that there's people trying in this room to develop more evidence for physical activity in cardiac rehab. So only 1 study in all of these papers showed any improvement in major adverse cardiac events. So this is not really enough to be sure. These were not all randomized controlled trials. Many of these were studies of cohorts and so on, and this doesn't give us enough information to be confident about what we're saying here. We did note that in the studies that had tried to increase aerobic duration, it works. Surprise, surprise, you put somebody on an exercise program and they get fitter. But one of the key findings is that exercise is not tailored to SCAD needs, and it's almost certainly too conservative for what we need to be doing for people who've had a SCAD. And there's not really clear guidance on appropriate physical activity. So the guidance that we currently have and what I'll present to you is expert consensus. It is not based on the evidence, and this is what we're trying to generate, and we hope that you'll help us generate this evidence. So in terms of psychosocial outcomes, One study showed that people improve if they get access to cardiac rehab and they have some emotional benefits. We're now fairly certain that people with SCAD, compared to age-matched controls, actually have slightly worse psychological outcomes. And whether that's because you get this sort of we don't really know, or what it is, PTSD is more common in this population than it is in women who've had a more traditional cardiac event. We're beginning to look at complex PTSD as well, which is where childhood trauma influences the likelihood. Now, we don't know if there's any association whatsoever, but we're beginning to think more broadly about how PTSD interacts. So again, I'm going to encourage you to keep in touch with us because we'd love to help us answer these questions. So we also discovered through our review that there's a very high level of perceived stress, fatigue and depression. And these are things that are critically important for your recovery from a cardiac event. We also believe that cardiac rehab programs from this evidence need to include family members because you do not live in isolation. You have to be working together as a team to address these needs. What was surprising to us was the high proportion of risk factors. We discovered that 32% of the population had pre-event hypertension, high blood pressure. Almost 30% had dyslipidemia. We're talking about high cholesterol here. So there's quite a number of people who have high cholesterol. Now, it may not be in the least bit associated with SCAD, but we shouldn't just be thinking about your SCAD, we should be thinking about your general health. About a quarter had fibromuscular dysplasia, and you're going to hear lots more about that today. And quite a large number have migraines. And, you know, certainly this is something that's really interesting, this association between migraines and SCAD. Now, this may just be a feature of the general population. If you look at the general population, this is not that surprising. But in a population with SCAD, around 45% are overweight or obese. Now, does this cause SCAD? Who knows? We'd love to find out. And we'd love to find out if reversing that, if helping people to lose weight, also influences them. We know in the general cardiac population that losing weight is of benefit. Is it of benefit in SCAD? That's a question we want to answer. Chest pain, which is absolutely critical. And this was one of the things that Mary really pointed out to us, was how many people suffer chest pain. More than half will have ongoing chest pain. Now, we know from Dave's work that that's unlikely to be ischemic chest pain, where it's as a result of your coronary arteries not functioning properly. But it seems to last for up to 2 years following a SCAD event. So why is that? We don't know. How can we manage it? Hope we'll be able to give you these answers. So this is the review. If you want to take your phones out, this QR code should link you to the full paper if you want to read it. And I would encourage you to take your phones out because I've got lots of QR codes nested in this. So as you can see, Mary was a co-author on this. Certainly one of the most valuable people I've worked with, and has really changed my practice and my thinking about involving patients in studies and designs, because the utility of having that voice just can't be understated. So, following on from this, we were lucky enough to have a master's student who approached us wanting to do a project. So we said, right, we want to find out what happened to people who had a SCAD, and what was their experiences of the recovery pathway and the support that they would want through cardiac rehab. So we did 20 semi-structured interviews. The majority were female, but we mustn't forget that this does also affect men. So one man, and the mean age was 54. And in this qualitative study, and again there's a QR code there if you want to read the full paper, what we found is that the survivors who were recruited, and many of you may have spoken to Kirsten, we recruited them through Beat SCAD and through our own social media channels. All of this was conducted via Teams. It's been amazing realising that we can do these things remotely and not having to bring you all to our centres. And then the data was analysed just using a thematic analysis process. So what we found was that people want increased education. They want us to know more about what you're experiencing. And there's a shocking number of people who don't know enough about SCAD and who don't have the information to support you when you need it. So we do need to increase the healthcare professional education. We need to provide accessible information, and Beat SCAD does a wonderful job with that. But we think we can go a little bit further. What we do need is tailored physical activity advice. And this is where we have some challenges because we don't fully understand the relationship between physical activity and SCAD, but hopefully we'll be able to do that. And we need to design a program that is accessible and suits your own physical activity preferences. So when you go to cardiac rehab, the majority of cardiac rehab services in the UK will offer you a circuit-based program where you get on an exercise bike and you exercise for 2 minutes and then you get off and you walk to the next piece of equipment and you do that again. That is not what we have found that people like to do when they're in a free living environment. So we need to be thinking about this. So it's important for us going forward. We found that a lot of people found the benefit of using a wearable to track their physical activity. And no surprise, people want psychosocial support. They want to have people understand what they're going through. And many people have had a traumatic journey to diagnosis, a prolonged journey, or been told that they're anxious, as we've already heard. So it really is important to have people who understand the condition. This kind of scenario where you're all together here, social support, meeting others with the same condition, was also considered to be invaluable. And they really wanted opportunities for longer term support beyond the cardiac rehab duration. So I'm just going to highlight another program because there is quite a lot of work going on in this space now around the world. It's all early and we are connecting with each other. So this is actually Barb Murphy's group in Melbourne and Adelaide. And they looked at 172 people, again, majority female, who had had a SCAD event to see what happened. And essentially, they found that on quality of life measures, there was a very, very key correlation or relationship between the quality of care you received and the experience, your quality of life. So this is why I think these SCAD clinics are absolutely crucial, because you're likely to get care where people really understand what you're going through. When something is relatively rare, then it means that the advice you might get will not necessarily be truly tailored. And I've had people tell me that they were told not to hoover because that was going to put too much strain on their heart. That really is not what we think, but we need to correct these messages about this. And so they've also looked at the internet. We think that a digital intervention is likely to be most useful because of the spread, because you're not likely to be able to have a single cardiac rehab intervention at one centre because there just isn't the volume of people. So we think that the intervention is going to be most likely to be beneficial in person. And almost half of these patients in this study reported a need for psychosocial support. So you're not alone if you are suffering with your psychosocial symptoms. This is really common in this population. So again, if you want to read that, that's the link to the paper. I will just say that we are also currently hoping to have funded a large study that's being led by the Canadians looking at psychosocial health in SCAD. So we're just waiting for the outcomes of that. So exercise, is it a cause of SCAD? In the literature, it suggests that there may be physical stressors in about a third, but they may not be directly associated. So you might have done a marathon on Sunday and have your SCAD on Thursday. Is that related or not? Who knows? We really don't think that that's actually, if you look at other cardiac events, you're likely to have them during the event, and then you can say there's a cause, but it might just be an association. Isometric lifting, which is where you lift to the point of valsalva. So valsalva is when you do that puffing kind of, you're contracting that muscle there and it's really straining. So as a cause of SCAD, it's more prominent in men. Men are more likely to do isometric lifting as well. So do we think that you should avoid isometric lifting? Probably, but we don't quite know where that lies. So what we do think is you can probably lift small weights, and the general advice would be to lift small weights more often. This is all observational data only, so we still haven't got trials. There's no increased risk in elite athletes, and the exercise, as I say, is not always at the time of event, and it's only an association. It's not a cause, so don't think that you can't ever exercise again. But there is some advice. However, we tend to take a very conservative approach at the moment, and that may not be appropriate. So this is what the expert group recommended. And there's an expert group of cardiologists, and there's really a need for us to generate the evidence here when we say what is recommended and what's not recommended. At the moment, we're suggesting avoid abrupt high-intensity exercise. So that might mean having a longer warm-up to get to that point. We shouldn't lift weights that force us to do that Valsalva manoeuvre. And contact sports are discouraged. Extreme head positions, and again, that sort of, yoga poses with extreme head conditions. This is consensus. We genuinely don't know, and we would really like to find out, because one of the theories is that women actually prefer yoga as an exercise modality. So if you're doing yoga, then let us know, and we would love to talk to you about any positions that cause you problems. The ones that are more likely to cause problems are obviously headstand, which not many of us who do yoga are likely to do, possibly back bridge, possibly plank and downward dog, but we don't know. So help us find out. So we are now in the process of developing SCAD-specific cardiac rehab. And we think from the evidence that we've gathered already that this is what it needs to include. So it needs to include information about menorrhagia, heavy bleeding. We know that about 68% of women who are put on aspirin will experience heavy bleeding. And if that hasn't been told to you before, why not? It's important to understand that this is a common finding with aspirin. We've already talked a bit about the need for advice on contraception and pregnancy, and we very much need to talk about menopause and HRT. And this is a study that Dave's hoping to get funding for to do in the near future. So we would really like to understand that relationship between menopause and HRT. We think that it needs to include information about recurrent chest pain. Clearly, over half of patients are reporting recurrent chest pain, so we need to understand what advice to give when you get chest pain. We also know that some of the medications that you may be asked to take might cause hypertension, so your blood pressure to be too low. And we've talked about PTSD, anxiety and depression. We definitely think there needs to be a psychosocial component to cardiac rehab. And again, exercise recommendations. And we suspect, but don't know, that we should avoid chiropractic treatments. Again, things that put sudden sharp pressure on your vessels probably is not a good idea. So again, Mary, we were so lucky to get this grant from the Burdett Trust for Nursing, inspired by all the work that we've already done with Mary. And Mary is a collaborator, as is Margaret, on this grant where we're trying to develop a recovery programme. So this is co-design of a recovery intervention. We are hoping to work with you. We're also looking at developing what we call a PROM, or a patient-reported outcome measure, because we think there are certain things that are unique to this population that should be gathered together that we can measure before and after. And we really want to increase the understanding of safe exercise. And we've had all sorts of exciting discussions about how we can do this. So I really hope that you'll continue to collaborate with us and help us here. So we have a final QR code for you here, which is just to sign up to be notified of any research that we are doing. So we can keep in touch and tell you about the programs. We will also, of course, share it with Beat SCAD, but we're hoping that we can develop a pool of people who are willing to participate in research through this and are happy for us to contact them to do this. Just one other pitch for another research programme that we are running at the moment, which is a James Lind Alliance Priority Setting Partnership in Digital Health. And so again, Beat SCAD have very kindly shared this for us, but there will be information circulating that you can look at. And really what we're trying to do is find out what digital technologies would make your experience of heart health better. So there's only two questions. The first is what currently might help and how could it be used? And the second is if you could design something that would make your life better, that's a digital tool, what would it be? And feel free to kind of dream what would make your life much better. So thank you very much for listening. We really wanted to get involved with this work because it's just so exciting to be part of and to be contributing to this. At the end of that slide were contact details, but if you've signed up onto our sheet, we will be in touch. So happy to take any questions.
Hi there. You mentioned chiropractic at the end of your presentation. Have you also looked at osteopathy and physiotherapy on the body?
We haven't looked at this. Is just expert consensus just now, so we haven't looked at either. But the consensus being that with chiropractic, they are more likely to do a manoeuvre on your neck that can cause dissection in your cerebral artery. So we really need to be careful if you potentially have arteries that might be likely to dissect with treatments that might do this. But it is just consensus. I'm not sure that I'm willing to start up a study to see if we can give you all chiropractic, but I think that might have trouble getting through ethics.
When we get discharged from hospital and we go onto the cardiac program, where does that information actually go? Because you get sort of like a questionnaire that you get to fill out, and the questionnaire seems very generic. It doesn't seem specific for, obviously, SCAD. So I just wanted to know, does it get fed back to the researchers, or does it literally just go on top of a cardiovascular pile and just be left?
Well, to a certain extent, it depends where your centre is. So in England, Wales, and I think Northern Ireland, they contribute to a national audit, which is affectionately known as NACR. It's National Audit of Cardiac Rehab. And they feed back the data, and that data then gets reported on. In Scotland, we don't contribute to NACR. So we are even worse in a position, we don't know where all the data goes, and it's something that we're trying to address within Scotland. But NACR was established in about 2002, and cardiac rehab is still delivered in the same format. And so it's based on that very traditional format, which hasn't really evolved over time. It was established when people were put on bed rest for 6 weeks after a heart attack, and they really did need rehabilitation. So one of our, I suppose, challenges or call to arms is to try to revise cardiac rehab to make it more functional and more specific to the population that we are looking after, and to make sure that we get that data in a way that is useful. We think in Scotland we can create a linked data set, which would actually be much more valuable because that data would be collected normally anyway, and that linked data set will help us understand what everybody in Scotland is getting for cardiac rehab. But that's something that we're working on just now. Collating and reporting into NACR is voluntary. It's strongly encouraged. I think about 70% of cardiac rehab programs do collect it, but the data is only as good as the data that goes in. So if they aren't collecting SCAD, we can't disaggregate it and we can't find out anything useful about it.
Hi there. Just a quick question. I am probably one of the extreme exercisers there to the point where I collapse in a heap, rowing and things like that. I'm getting back into exercise kind of 4 months after. But I just want to ask generally about heart rate, because I know just about everybody here that's in exercise, I was obsessed with my heart rate before, but I'm obsessed for a slightly different reason. How important for everyone here is your heart rate when you're exercising?
I'm going to pass this one on to Coral because Coral is our exercise specialist. By the way, if you want to speak to the team, we're all wearing Cardiovascular Health Centre t-shirts so you can recognise us. So Coral is Senior Research Fellow in the Centre for Cardiovascular Health and a long time exercise specialist.
Yeah. So I think I'll be careful what I say here because Dave's probably staring at me. So in general, you can look at your heart rate and you can predict what your maximum heart rate is, as I'm sure you're aware. And you can then say, well, it's beneficial to my heart to exercise at somewhere between, this is very generic here, but somewhere between 60 and 80% of what my maximum heart rate will be. And if you exercise slightly higher, then generally, if you've not got heart disease, that's not a problem. You benefit from doing a lot of exercise in terms of aerobic endurance training and actually doing it at the lower end of that, so around about the sort of 60 to 70% with a small amount at the higher percentage. But most people like to, well, I suspect you're like me, I like to go out and really like blast and exercise really hard at a high heart rate. And I just had this conversation with Dave yesterday about what he would advise me if I was to have a SCAD. The answer is we don't know about whether it is okay for you to exercise at those higher heart rates at the minute. And the reason that it says moderate intensity exercise is because the evidence is not there. It's not to say that it is not safe to exercise at a higher heart rate. And Alice, who's here, has maximally exercised people who have had multiple SCAD, is that correct? Yep. And there's been no problems with angina, so the heart has still been getting enough oxygen to be able to function properly. And so the chest pain that you're getting with exercise is unlikely to be related to that issue. So I guess, yes, you can use, so the question is, can I exercise at a high heart rate? We don't know. Should we be obsessed with heart rate? Probably we shouldn't be obsessed with heart rate. We should be thinking about how we feel with exercise. However, if you're just thinking about how you feel but you don't understand your heart rate at all, then that can also be problematic. So I don't know that that actually answers your question, but I think we also want to know more about it, and I can see that you're wearing a wearable there, so this is a little bit of a pitch. That we're really interested, so anybody in the room who has a wearable, who wore a wearable before they had a SCAD, we're interested to try and see if we can access your data from screenshots from before you had a SCAD, immediately after you had your SCAD, and then a bit of time after, so that we can actually look and see what's changed. And yeah, so you've probably already done that. But we'd like to get a group of set of data together where we can have a look at that and try and understand it. And obviously, after you've had SCAD, you're probably beta blocked now, so your heart rate reacts differently.
Thank you.